This will be the lecture on the vestibular system, and we'll also include the cerebellum as well, just because some of their functions go hand in hand. As far as the overview for the lecture, first we'll go over the anatomy. To truly understand the vestibular system and the clinical signs that occur, I think it's helpful just to have a basic understanding of the anatomy of the vestibular system, and eventually we'll talk about the cerebellum. And then we'll go into the clinical signs and how to differentiate peripheral from central vestibular disease. And then we'll go into the differential diagnoses and the treatments. This video that we see here is a patient that has congenital vestibular disease. And it's not common in the Cavalier King Charles Spaniel, but every once in a while we'll see it in them. As far as the function of the vestibular system, there's three main things that it does. First is it maintains posture and balance of the head relative to the body and the limbs. The next thing that it does is detect acceleration and deceleration. It's the only part of our body that does. If you move your arm back and forth, you know that it's moving because of your proprioception, but it's not detecting that acceleration and deceleration. And finally, it helps coordinate eye movement as well. So starting off with the anatomy, we're going to be within the caudal portion of the skull, and here the arrow is just pointing out the bulla. On the left is a T2 weighted sagittal MRI, and on the right is a T2 transverse. And as we scroll caudally through the transverses and get to the level of the medulla, we can see the different anatomical parts of the vestibulocochlear apparatus. Going into more detail, again on the left is a T2 weighted sagittal MRI, and that's just to orient you as far as where we're at. So again, kind of right at the junction between the medulla and the pons. The right is going to be a transverse CT, and there are certain anatomical structures that you should be able to recognize. Starting with the external ear, we have the horizontal canal, and it's going to be separated from the middle ear by the tympanic bulla, or the tympanic membrane, also known as the eardrum. And then there's going to be the inner ear, which is the vestibulocochlear apparatus. The cochlear portion is going to be for hearing. The vestibular portion is going to be for the vestibular system. And then there's also the vestibulocochlear nerve. And that's going to be the nerve that traverses that information. This portion, the vestibulocochlear apparatus and the vestibulocochlear nerve, is going to be the peripheral vestibular system. So we'll take a closer look at this vestibular system, the vestibular apparatus now. So as far as some of the major players that you should be aware of, there's going to be the ampulla, which sit at the base of the semicircular canal. And then there's the utricle and the saccule. The utricle is more for horizontal acceleration, the saccule more for vertical acceleration, and then the ampulla is going to be for rotational movement. So just going into a little bit more detail on the utricle. On the left is just a zoomed in image of it. And within the utricle are these statoconia. So there's these often called otoliths, and these otoliths have weight to them. So when there's a change in direction or some sort of acceleration, because of that weight, that mass that the statoconia have, it's going to pull on the rest of the saccule. So there's just gelatinous type structure that these hair cells will sit in. And when that gel gets pulled in a certain direction, it's going to change the firing rate of those neurons. So normally when a patient is just standing there, there's going to be kind of this basal rate that those hair cells put into the central nervous system. And that's going to say this is the normal pull of gravity here on Earth. Again, it's just this basal rate, so that way the animal knows how to maintain their posture, how much force needs to be put into those muscles. And if there's a change in that acceleration, then that rate is either going to speed up or slow down depending on what direction that acceleration is. So that's going to increase tone of certain muscles, decrease tone of other muscles, so that way the patient doesn't fall over again if there is acceleration or deceleration occurring. So this is just an animation kind of depicting that. Again, if there's acceleration, then there might be an increase in that rate of firing in those hair cells because those statoconia are pulling on that gelatinous structure, which changes the position of the hair cells and changes the firing rate. Looking at the saccule, just more the vertical type direction. Again, it's a similar thing. And all that information, those axons are what form the vestibular portion of the vestibulocochlear nerve. Now we'll talk briefly about the ampulla. So as we mentioned earlier, we said that the ampulla detects rotational movement. So the head's turning side to side. It's a similar situation, but there's no statoconia on the ampulla. The difference is you're going to have the endolymph that's going to brush over that ampulla, the crista ampullaris. And because of its shape, it causes it to push one direction or another. Again, the same concept of a change in firing rate depending on the rotational movement. And this is going to be in the X, Y, and Z plane. And that's why there's 3 semicircular canals with an ampulla at the base of each one, because it detects acceleration, deceleration, or change in rotation in the X, Y, and Z plane. And this is just an actual artist drawing of the inner ear. As far as the inner ear, we'll be a little more simple with it. There's just the vestibular nucleus, and then the vestibular nucleus is within the medulla, and then there's what's called the flocculonodular lobe, and that's going to be within the cerebellum. So this is what makes up the central vestibular system. As far as how the vestibular system works, it can be a little bit confusing because there's only an ipsilateral tract, but it has contralateral influence. So we'll go through that in some detail here. So remember that when there's the influence of gravity, which is acceleration, we're going to have this normal basal rate, this normal firing from the ampulla, the utricle, the saccule, all that is going to be fed through the vestibulocochlear nerve to the vestibular nucleus. There's going to be some influence from the cerebellum, but all that information is going to be fed through the vestibulospinal tract and then eventually to the anti-gravity muscles. That's going to excite their tone and help with posture and helping the patient stand upright. There's also influence to the contralateral side that's inhibitory to those extensor muscles, but because the input is coming from both sides, everything evens out. So that inhibitory signal during normal physiologic functions, we can pretty much ignore. Another thing we mentioned earlier is that the vestibular system is responsible for coordinating eye movement. I'm not going to go into a ton of detail with this, but just know that when the eyes are having that clicking type motion, it's going to be cranial nerve 8 as the afferent, and then 3, 4, and 6 are going to be the efferent. So this is known as the oculocephalic reflex, or it's often called physiologic nystagmus as well. So as those ampulla are being pushed over, again within those semicircular canals, they're detecting that rotational movement. There's going to either be excitatory information or inhibitory information being sent to the eyes depending on what direction the head is turning, or to those extraocular muscles. And what we should see, as you see in this video on the bottom left, is this fast click in the direction that we're turning the head, and that's going to be our normal oculocephalic reflex. As far as some additional considerations when we're talking about the vestibular system and localization, remember that the facial nerve is going to cross and go into the middle ear. So disease of the middle ear can cause facial nerve deficits, and it also exits in the same place as the vestibulocochlear nerve. So issues with the vestibulocochlear nerve, if there's inflammation, can also cause facial nerve deficits. And then the sympathetic innervation to the eye is also running by the middle ear. So disease of the middle ear, especially when we're talking ventral medial, can cause Horner syndrome. And this is just a patient that has middle ear disease and a facial droop on the patient's left side, so our right when we're looking at the patient. And then just a quick refresher on Horner syndrome. Remember that the sympathetic innervation to the eye is going to originate within the hypothalamus. That information is going to travel through the pons, the medulla, and then the cervical spinal cord. There's what's called the lateral tectotegmental spinal tract. That's what most anatomists feel the tract is for the sympathetic nervous system, but there's not true consensus on that. But again, if you hear tectotegmental spinal tract, they're usually referring to the sympathetic tract. From there, it's going to synapse, typically with on T1, T2, and T3. It'll exit their respective foramen, and then it will join up with 2A there, the ramus communicans, and then start going cranially. A is depicting the cervical thoracic ganglion. There's no synapse there. It's just passing through that ganglion. B is going to be the middle cervical ganglion. Again, there's no communication or no synapse there. It's just passing through it. 2B is going to be the vagosympathetic trunk. So the vagus coming down from which is cranial nerve 10. So coming down from the medulla to the rest of the body, whereas the sympathetic tract is coming rostrally or cranially at this point. C is where the second synapse occurs. That's going to be within the cranial cervical ganglion. It's right at the base of the middle ear. And then 3 is going to be the post-ganglionic nerve fibers. And that's going to traverse again through the middle ear, through the skull, and eventually make its way to the eye. As far as the clinical signs of Horner syndrome, we can see most of them in this dog on the right. So meiosis is going to be the most important clinical sign when we're talking about Horner syndrome, but they typically also have ptosis in ophthalmos and protrusion of the third eyelid because of that in ophthalmos. And then for those that need to remember about horses with Horner syndrome, remember that they'll have sweating as well. We should be pretty familiar with clinical signs of vestibular dysfunction. So often they'll have an abnormal posture. So a head tilt is going to be the most common posture that we see, but we can see another posture called the archer posture, which I'll show you in a little bit. Of course, they can have vestibular ataxia. Sometimes this can be quite difficult to differentiate from other forms of ataxia because it can be so severe, or it could be a combination of ataxias present. Of course, strabismus may be present, but a lot of times when there's vestibular dysfunction, it can be acute and severe. So it's hard to appreciate the strabismus because we have nystagmus or spontaneous nystagmus, pathologic nystagmus that are present, like what we see in this horse here. So it's hard to truly appreciate could there be a strabismus, an abnormal position of the eye, because we're seeing these spontaneous movements of the eye. Another clinical sign that we can see from vestibular dysfunction is going to be nausea. So I'll just briefly touch base on this. As far as some of the key players we need to know about, there's the vestibular nucleus within the medulla, and then there's also going to be the chemoreceptor trigger zone we'll talk about, and the vomiting center. So when there's vestibular dysfunction and there's a change of input going into that vestibular nucleus, that's going to also have an effect on these other areas of the brain. So here's our signal, irregular signal that's coming down, communicating with the vestibular nucleus. That information is going to then stimulate that chemoreceptor trigger zone. This is where nausea is going to come into play. And eventually, if that nausea is so severe that input coming from that chemoreceptor trigger zone, also known as the area postrema, is high enough, it can cause vomiting. So I've labeled some of the areas that we can actually do things when it comes to medications and helping with the feeling of nausea and vomiting itself. Something I haven't talked about yet are these NK1 receptors. For those familiar with Cerenia, you know why I'm bringing it up now. But in a normal physiologic state, as far as I know, we're still not sure exactly what these NK1 receptors do. So if we have a patient that has mild signs of nausea associated with vestibular disease, or maybe it's really severe and we want to hit it multimodal, one medication that we can give is an antihistamine like Dramamine, because that's going to bind to the H1 receptors within the vestibular nucleus. We can also give a more effective medication called ondansetron. It's going to bind to that chemoreceptor trigger zone. Remember, the chemoreceptor trigger zone is not surrounded by the blood-brain barrier. So a medication like ondansetron doesn't need to cross the blood-brain barrier, and that's why we don't have to worry about other serotonin side effects, because again, it's just going to be working on this part of the brain that's not actually surrounded by that blood-brain barrier, and then it's going to prevent the feeling of nausea. There are some studies that say ondansetron's better for vestibular disease because the feeling of nausea is the worst part, and eventually that is what leads to the vomiting versus just blocking the vomiting from happening. So you will see us not too uncommonly start with ondansetron before we give something like Cerenia. Again, if we're looking at multimodal, how can we treat the nausea? Metoclopramide is a way to block those dopamine receptors at lower dosages. The metoclopramide is not going to cross into the blood-brain barrier, again, which is okay because that's not what we're wanting it to do. We want it to have its effect on that area post-strema. And then finally, we can give meropitant, and that's mainly going to help with vomiting. It seems to have some effect on that chemoreceptor trigger zone and maybe some effect on nausea, but doesn't seem to be to the same degree as ondansetron. We're not going to do much for the muscarinic. That vomiting center is also protected by the blood-brain barrier, so it can get a little bit dicey when we're talking about trying to just affect the muscarinic receptors on the vomiting center, because there can be a lot of potential side effects with a medication like that. For our neurologic exam, of course, the biggest thing when we have a patient that presents with vestibular disease is differentiating central from peripheral, because that's going to establish our differentials, what the next diagnostic procedure should be, and to some degree help with prognosis. One of the most important aspects of our neurologic exam in differentiating central from peripheral is going to be the level of consciousness. Now, some of these patients can be so disoriented from the vestibular disease, they might appear lethargic or even obtunded to some degree, but it should be more on the mild side of things when all things are taken into account. Whereas with central, this is when we start to be more confident if a patient is obtunded, stuporous, or especially comatose, that this would be a central localization. And it might sound bizarre, how can a comatose patient be vestibular? But I have seen it on occasion to where they are completely non-responsive, but they still have nystagmus, they still have a head tilt, and they can still have an archer posture as well. So it's not common we see that, but again, they can still be vestibular even in a coma. The reason for it, the medulla is going to be where the vestibular nucleus is located. So if there's a lesion near that vestibular nucleus, it can affect that ascending reticular activating system, which is going to lead to the mentation changes. Now, a central lesion doesn't always cause mentation changes. So just because the mentation is normal, or if they're just disoriented, it does not completely rule out a central localization. As far as abnormal posture, the reason why we see the abnormal posture is because there's going to be a change in firing rate in one side of the vestibular apparatus. So we completely lose that input on one side, and that's going to cause a decrease in tone on that side of the body where the vestibular system is affected. This is just going into the previous slide in a little bit more detail. So if there's a lesion on the right side affecting the right vestibular system, we're going to lose that input. So we've lost the tone going to the anti-gravity muscles. So we're going to have decreased tone on the side of the lesion. Additionally, we're going to have further decreased tone because of that inhibitory signal coming from the contralateral side. So the side that's still functioning now has additional influence on those anti-gravity muscles, making it easier for the patient to fall towards that side. There's decreased tone on that side. And it's not uncommon that because of that decreased tone of the anti-gravity muscles, the extensors, that it almost seems like we have increased tone of the flexor muscles, and we can sometimes get what's called an archer posture that you can see on this image on the left. So the cat's left leg has severely increased tone, and the right leg is in this flexed position because there's almost complete loss of tone going to the anti-gravity muscles. Additionally, there's more tone on the side that's still functioning because there's no decreased tone coming from the contralateral side that's affected. This is why a patient will have a head tilt towards the side of the lesion when we're talking about central or peripheral vestibular disease, because there's decreased tone going to the neck muscles as well, so the head's going to tilt towards that direction. Additionally, there's increased tone on the other side too. Gait is not quite as helpful for differentiating central from peripheral as compared to some of the other signs on our neurologic examination. Of course, with peripheral vestibular disease, we would expect to see vestibular ataxia. It could be mild or severe, sometimes so severe that they will just keep rolling. With central, these patients might have proprioceptive ataxia as well. They could have cerebellar ataxia or hypermetria. And of course, they can have paresis or even plegia on one side, but those aren't always present. And just like with consciousness, just because a patient only has peripheral or only has vestibular ataxia, it doesn't mean that it can't be central. Postural reactions are going to be more helpful than gait most of the time. If a patient does have postural reaction deficits on one side, and it's the thoracic and the pelvic limb, then we can be pretty confident that it is associated with the vestibular lesion. The problem comes when it's only the pelvic limb on one side, or if it's both pelvic limbs. We don't know if it is a patient that's just an older patient that also has a T3L3 myelopathy as well. So just because we don't get deficits, it doesn't mean that it's not central either. So when we have a patient with strabismus, a lot of times we are worried about vestibular disease. The type of strabismus is not always helpful as far as differentiating central from peripheral. In fact, most of the time it's not. And a lot of patients, again, vestibular disease is often acute and severe, so we see nystagmus instead of a strabismus. With pathologic nystagmus or spontaneous nystagmus, this is when the patient is at rest and we're seeing the nystagmus, that eye twitching, occur despite us not moving the head. These can be rotary, horizontal, vertical, and typically we say if they're vertical, it's more likely to be central, but there's a couple recent papers that say that that's not always the case. And sometimes it's very difficult to differentiate rotary from vertical. Of course, horizontal can be with peripheral or central. If there's a change in direction, so at one moment the eyes have a fast face to the right, we put them in a different position and now it's fast face to the left, that's going to be much more likely to be central. Or if they're just positional to begin with, so the patient doesn't have any nystagmus and then we lift their head straight up and all of a sudden they have horizontal or vertical nystagmus, that's more likely to be central as well. And this slide is just going through that. Again, change in direction can be quite helpful as far as differentiating central from peripheral. And by change in the direction, we're usually meaning fast phase to the right, and then it goes to the left or vice versa. So here's an example of a patient that has what are called disconjugate nystagmus. So you'll notice both are vertical, but one eye is going up while the other eye is going down. So it's going to be more consistent with central. Other cranial nerve deficits, if it's 7 or sympathetic, then that can be peripheral. If a patient has Horner syndrome with vestibular disease, it's almost always peripheral unless they have severe mentation changes. So if there's not a severe mentation change and we're seeing that, again, it's almost always peripheral. With central, of course, 7 can be affected along with other cranial nerves. And the picture on the right is just depicting a dog that has decreased muscle mass on the right side because there's also cranial nerve 5 involvement. So much more likely to be central in that patient. This is just a chart that's kind of going through all that information. I'll leave it here for just a couple seconds and you can look through it if you have any questions. And this is just a case. I'll let it play through and I'll let you know at the end if this was central or peripheral with our localization. But before we get there, just watch the video and see if you can localize if you think central or peripheral. Not the most cooperative patient. This is a good example of vestibular ataxia. You can see the patient leaning towards the right, drifting towards the right. There's the head tilt towards the right. But ask yourself, are you seeing other signs of ataxia or paresis? Is there knuckling? Is there crossing over? You can see me pulling on the leash to help keep this patient on the mat. So this is a case that has peripheral vestibular localization. Again, when we talk to the owner, we say we're localizing peripheral. We're not getting any other deficits that make us think central, but about 20 to 25% of cases that have a peripheral localization will actually have a central lesion. And this dog ended up having a brain tumor, unfortunately, within the medulla. So again, just because we localize peripheral, we always have it in the back of our minds that it could be central. If we localize central, most of the time we're correct. Going through differentials, this is by no means a complete list, but this is probably 90% of what you'd be dealing with, maybe more, when we're talking about peripheral vestibular disease. And we'll go through some of these now. Before we get into the differentials, we'll just go through the diagnostic approach. Of course, anytime you localize to the peripheral vestibular system, an otoscopic examination is going to be recommended. It's not always the most helpful, but sometimes you'll see something obvious like horrible ear disease or potentially a mass. Going one step beyond that, there are radiographs that can be done of the bulla to look for any sort of obvious lysis to the bone or potentially increased opacity within the bulla itself. They do have a low sensitivity and specificity, so we usually skip this, but if you don't have CT or MRI, it is better than nothing. Of course, CT is going to be the gold standard when it comes to looking at the bony structures. So if we're worried about the bulla itself, the bony structures, CT is going to be preferred. And it is a good test for looking within the bulla as well. It does have limitations looking within the brainstem. There's what's called the petrous portion of the temporal bone, which is the most dense bone within the body. And there's a lot of beam hardening artifact that occurs within that region when we're looking at the CT. So it's not uncommon for more subtle lesions on CT that they will be missed. Even something like a meningitis can easily be missed on CT. So from a neuro standpoint, that's why we usually prefer to do MRI when we're looking at even the outer portion, the middle ear. Bear testing is kind of hit or miss if the owner is also worried about hearing loss or we're kind of following up. Maybe we did a myringotomy, the owner's worried that the patient can't hear still despite our tests or despite our treatment. then we might do a Bair test, but usually not something we perform. And then myringotomy, where we poke a hole within the tympanic membrane and try to obtain a cytology culture and maybe clean out some of the debris. As I mentioned earlier, CT is going to be the gold standard when it comes to looking at the bone, but you can see within the middle ear pretty well. And this is just an example of a CT with an animal that has otitis media. Of course, MRI for us is going to be the preferred choice, but again, there's times where MRI is not necessary, but if we have a lesion to where there's just meningitis, like in this patient, it could be pretty easy to miss on CT. So this could easily be mistaken as an animal that just has otitis media when there's actually extension into the brain itself. The most common infections for otitis media interna is going to be Pseudomonas, followed by Staph, E. coli, and then Klebsiella. There are non-infectious forms of otitis media, so what's often called PSOM, primary secretory otitis media. It's also called otitis media with effusion. No one seems to agree on what the best term is for this. The layman's term is glue ear, but basically there's fluid within the middle ear itself, and that can end up causing vestibular signs, and it's non-infectious. As far as treatment, if the tympanic membrane is ruptured, which usually in cases with otitis media interna it's going to be, we need to be cautious with topical treatment just so we don't make matters worse. We usually treat with oral antibiotics, so either Clavamox or Baytril to start with, but ideally we would base it on culture. But it's not common that I feel confident in the culture results, or we get culture results that are negative despite there being pretty nasty looking ears. And when we do a myringotomy, we can often get a lot of material out, but again, the cultures aren't always the most helpful, at least in my hands. And then for severe cases of otitis media, or if there's recurrence, then the TICA is going to be recommended. Additionally, if there is extension, meningeal extension of otitis media interna, TICA seems to be a very good treatment for those cases, and they have a much better outcome compared to animals that just receive a myringotomy. As far as performing a myringotomy, this is something that we typically do after MRI or CT is performed, just so that way we can confirm that our highest suspicion is otitis media interna. As far as some areas to recall when it comes to the tympanic membrane, there's the pars tensa and the pars flaccida. The pars flaccida is going to be dorsal. When we're doing our myringotomy, we want to go within the caudal ventral region into the pars tensa because that's going to be less vascular, so there's going to be less hemorrhage, and it's going to be more likely to heal as well if we go through the pars tensa. There are potential side effects with doing the myringotomy, so facial paralysis can occur afterwards. Sometimes it's temporary, sometimes it can be permanent. Vestibular signs can be worse after doing it, so it's not a benign procedure. And then hopefully on this image, everyone's able to recognize what is going on with this cat. So inflammatory polyps are another cause of middle ear disease and extension to cause otitis interna as well. So it's usually not the polyp itself that's causing the vestibular signs, but the secondary inflammation that occurs. Often these cats will have upper airway signs, and they are rewarding when you can get good traction and pull out these oropharyngeal polyps, but they can recur. And there's definitely evidence. There's 3 studies now that I know of that show putting them on prednisone therapy or corticosteroids after the polyp is removed decreases the recurrence by quite a bit. The percentage that I have is if you don't put them on corticosteroids, it's 50-50. If you do put them on corticosteroids, it's less than 10% chance that they recur. And again, they can be quite rewarding when you can pull these out. There's a number of different aural neoplasias that can cause vestibular signs. Fibrosarcoma, chondrosarcoma are probably going to be some of the more common ones. Of course, lymphoma in cats as well. Osteosarcoma has been reported. Ceruminous gland adenocarcinomas, squamous cell carcinomas have been reported too. Treatment is usually not great in these circumstances. Combining surgery plus radiation therapy is probably the best option to try to get some degree of a decent long-term prognosis, but it's rare that the vestibular signs reverse, so we usually have to manage the clinical signs of nausea and dizziness in these patients long-term. Idiopathic vestibular disease is extremely common, especially in dogs, not nearly as common in cats. In dogs, we usually think of older dogs. It's often called old dog vestibular disease, but in cats, they're usually more middle-aged to maybe even younger when it occurs. It's a pericute onset, so these animals are normal, and then just out of normal, they're severely vestibular. The good part about idiopathic vestibular disease is it usually resolves within 1 to 2 weeks. When I say resolve, I mean that the patient is able to ambulate, there's improvement in their nystagmus and head tilt, but it's not uncommon that they have some degree of residual signs, especially with the head tilt. It doesn't mean they can't have a good quality of life, but it is important to remember that most of these patients, at least in my experience, don't have a 100% full recovery. We do put them on antiemetics, anti-nausea medication to help with the feeling of nausea, though. So don't overlook that aspect of it if you do think idiopathic. And it's thought to be seasonal in cats, or there's some reports that it is, but there's a lot of reports that say that it's not, so take that for what it's worth. Don't overlook some of the medications that can cause vestibular disease. So, of course, aminoglycosides are going to be some of the most well-known ones, with gentamicin being the most common to cause it. But there's other medications. So minocycline's been reported, chloramphenicol has been reported, that patients can become vestibular, and it's due to damage to the hair cells. And when those hair cells are damaged, they're like most neurons are not going to be able to regenerate. Their capacity to heal is very limited. So it's not uncommon that those clinical signs of vestibular disease are permanent. A patient can adapt to those vestibular signs, but they're never going to be the dog that they were before, or the cat. Furosemide's been reported to cause it. So the electrolyte balance within the inner ear is extremely delicate. And if a patient is on high doses of long-term furosemide, that can alter the electrolyte balance, and it can kill those hair cells. And then cisplatin is going to be another one, especially in cats, to where it's known to cause damage to the hair cells. So peripheral vestibular disease, the two most common causes are going to be otitis media interna and idiopathic. By far and away, that's going to be, at least looking at the studies, 70 to 80% of all peripheral vestibular cases. So usually the prognosis is good, especially if we treat it early and aggressive. If it is a more severe infection to where there's osteomyelitis, if it's a fungal infection, if it's neoplasia, then of course the prognosis is going to be worse in those situations. And then don't forget that facial paralysis, Horner syndrome can occur. If there is facial paralysis, then the parasympathetic portion of the facial nerve going to the lacrimal gland can also be affected. So not only can these patients not blink, they're not producing tears. So keep that in mind. Any patient that has facial paralysis or even paresis from vestibular disease, it's probably worthwhile checking tear production on them. As far as central vestibular disease, I'll pause here so you can look at the list, and we'll go through this in a little bit more detail for some of the more common ones. Again, starting out with the diagnostic approach, MRI is going to be recommended anytime we localize a patient with central vestibular disease, and sometimes we'll also do cerebrospinal fluid analysis afterwards, depending on what we find on the MRI. So anytime we have a patient you have a patient that's localized as central vestibular, we're going to recommend referral. I know that's not always going to be the case, but it's still going to be the recommendation. As far as the differentials, there's the inflammatory category. So this is the infectious, and then the non-infectious are often what's thought to be immune-mediated. And this is just an MRI. On the left is a T1 weighted sequence. On the right is a T1 post-contrast. And we can see that there's severe meningeal enhancement in this patient. Hypothyroidism is known to cause vestibular dysfunction as far as is it central or is it peripheral. There's a lot of debate, so I'm not going to get into the pathophysiology of it, but I have it listed there for those that are interested. Intracranial neoplasia is probably what most people think of when we talk about central vestibular disease. There's a number of different neoplasias that have been reported within the level of the medulla. Meningioma is going to be the most common, but other players like choroid plexus tumors, lymphoma, even gliomas have all been reported. Treatment for intracranial neoplasia in this location is usually quite limited, although surgery is possible in some cases. The vast majority, surgery is not realistically an option, and radiation is typically going to be the only option in most of these cases. Thymine deficiency can absolutely cause central vestibular disease. Remember that thymine is extremely important when it comes to energy metabolism, and the neurons within the vestibular system and within the cerebellum require a lot of energy. So anytime there's thymine deficiency, vestibular signs are sometimes the first clinical sign that's actually seen. With peripheral vestibular disease, we talked about some medications that can cause peripheral vestibular disease. Metronidazole is different because it will cause central vestibular signs, so proprioceptive deficits, mentation changes. The nice part about metronidazole, however, unlike the other medications we were talking about, is the clinical signs are reversible with metronidazole toxicity. Although when you look up reports, it says typically these are animals that are receiving high dosages of metronidazole, so greater than 60 milligrams per kg per day. Some patients are extremely sensitive to metronidazole, and it's been reported in patients that are receiving even in the 20 mg per kg of metronidazole per day. A treatment for metronidazole toxicity is diazepam. Personally, I haven't had that much luck doing it, but if you look up the antidote for metronidazole toxicity, they talk about diazepam, and I have the dose listed there for you. And lead is another toxin that can also cause vestibular signs. And then the brain is extremely vascular, as you can see in this image here. So of course, vascular accidents can cause vestibular signs, and it's actually a pretty common cause of central vestibular disease. So for the vestibular system, I kind of glossed over the treatment, especially when we're talking about infectious and MUE or meningoencephalitis of unknown etiology, but we'll have a whole separate talk on inflammation within the CNS, both infection and non-infection, so that's why I didn't go into a ton of detail. But if you have questions about the vestibular system, just let me know. I'm recording this late at night, so I might have said something incorrect. So again, just let me know if you catch something or if you have questions, but we'll now go into the cerebellum. So when it comes to the cerebellum, just like with the vestibular system, we'll first go over the anatomy, then we'll talk about the clinical signs, because depending on what part of the cerebellum is affected is going to dictate the clinical signs that we see. And then we'll talk about some of the differentials and potential treatment options for some of those differentials. So the cerebellum stands for little brain, and it's going to be looking at this T2-weighted sagittal MRI and transverse T2-weighted MRI on the right. This is going to be the little brain, the cerebellum. As far as some of the anatomical structures you might recall, there's the arbor vitae, the tree of life, which is going to be the white matter of the cerebellum, and then there's the cerebral cortex as well. Other anatomical parts to be familiar with is going to be the dentate, the interposital, and the vestigial nucleus, and that's going to live in the deeper part of the cerebellum. So it's not within the cortex, but it's deeper to that. Other anatomical parts to recall is going to be the vermis, that's going to be the center portion of the cerebellum, and then there's the cerebral hemispheres, which are the lateral portions of the cerebellum. So the way I like to break up the cerebellum is based on the function, because again, depending on where the lesion is at, that's going to dictate the clinical signs that we see. And we'll get into the function of each of these anatomical regions shortly. But there's the cerebrocerebellum, which is kind of the caudal portion of the vermis and more of the medial portion of the hemispheres. There's the spinal cerebellum, which is the rostral portion of the vermis and more of the lateral hemispheres. And then there's the vestibulocerebellum, or the flocculonodular lobe, and this is what's going to be involved when we're talking about vestibular dysfunction associated with the cerebellum. As far as the main function of the cerebellum, it largely helps fine-tune movement. So it's mostly inhibitory. So it gets motor commands, it gets sensory input, and then it's going to fine-tune all that movement so that way it's coordinated. And again, it's largely inhibitory. There is a lot of research that talks about the cerebrocerebellum, which again is that caudal portion, that it actually is involved with memory, involved with behavior, at least in people. We still don't know that much about it in animals, so I'm just going to largely ignore that at this point. Looking at things in a little bit more detail as far as the microscopic level, we have our white matter, the portions of the arbor vitae, but there's 3 layers within the cortex that you should be familiar with. There's the granular layer, which is the deepest layer, the molecular layer, which is the outermost layer, and then squeezed between those 2 layers is going to be the Purkinje cell layer. Just to kind of quickly go through how complicated this whole entire system is when we're talking about the cerebellum, I'll go through this chart here, and this is also to talk about those deep cerebellar nuclei. So earlier I mentioned the vestigial, the dentate, the interposital. Again, deep, kind of within the arbor vitae. They're going to be mentioned briefly here. So when we have that information come in, it can travel up different fibers, but the one we'll talk about now are what are called mossy fibers. And these are going to synapse within that granular cell layer, that deepest layer within the cortex. That information is then going to go up, and it's going to go into the molecular layer where those Purkinje cells have their projections. And there's different cells within the molecular layer. So as it's labeled there's basket cells, there's stellate cells. These are going to help as far as regulating some of that input that's going to the Purkinje cells. But eventually the Purkinje cells will fine-tune that movement, and they'll send it to potentially those deep cerebellar nuclei, and then from the deep cerebellar nuclei, that information goes out to the rest of the body. It could also, the Purkinje cells can directly communicate with on certain nuclei, such as the vestibular nuclei. And again, when we're talking about those deep cerebellar nuclei, it's dentate, vestigial, and interposital that we're talking about. As far as the clinical signs, again, it depends on what part of the cerebellum we're talking about. So things like intention tremors, hypermetria, that's going to be more the spinocerebellum. When we're talking about increased muscle tone, truncal sway, the generalized ataxia, and titubation, that's going to be more of the cerebrocerebellum. And then again, the vestibular signs we think of with the flocculonodular lobe or the vestibulocerebellum. And this is just showing some of those clinical signs. So here's the dog with an intention tremor. So we'd be more concerned about the spinocerebellum in this dog. This is a dog that has full body tremors, and this is by far and away most common with a condition known as idiopathic cerebellitis or steroid responsive tremor syndrome. So typically, the entire cerebellum is going to be affected when this occurs. Studies have shown that other parts of the brain are affected with steroid responsive tremor syndrome. So there is debate if a pure cerebellar lesion is going to cause tremors like this, but typically when we see tremors like this, we're going to think steroid responsive tremor syndrome, with the cerebellum being the main location for localization. This patient also had hypermetria, so this is that overflexion, overextension of the limbs when they're walking. It's more easy to recognize in the thoracic limbs, but it is present in the pelvic limbs to some degree too. And some patients just have more generalized incoordination. So when we talk about generalized ataxia, and it's hard for us to truly say what type of ataxia it is, it's often cerebellum that we're talking about with that. Towards the end of this video, when the dog looks at us, we'll see him shake his head side to side, back and forth, and that's titubation, that back and forth rocking movement. So all signs of cerebellar localization. Decerebrate rigidity can also be seen with cerebellar disease. The only time I've seen it is in cats with strokes. I've only seen it twice, so it's not common. But the classic hallmark is going to be extension of the thoracic limbs with flexion of the pelvic limbs, and they often will have that epistotonous or opisthotonous posture too. That's not always there. The two cats that I saw had normal mentations. Maybe they were a little lethargic, but they were very responsive. So that's going to be another way to differentiate decerebrate from decerebellate rigidity, is with decerebrate, those patients will be stupor or comatose. So a main reason I talk about the cerebellum with vestibular disease is a condition known as paradoxical vestibular disease. Again, we said that the vestibular system is going to be comprised of that vestibular nucleus and also the vestibulocerebellum, or the flocculonodular lobe. So the main purpose of the cerebellum is inhibitory. So we say that the vestibular nucleus has this normal basal rate. The cerebellum has some inhibitory influence on that, so everything is fine-tuned. So again, that information comes from the vestibular apparatus, goes to the vestibular nucleus, goes to the cerebellum, and then down to, or the cerebellum has influence on the vestibular nucleus, and then that information goes to the rest of the body. Everything is bilateral, so just because there's inhibitory signals going to the other side of the body, everything evens out. But if there's a cerebellar lesion, now we get increased signal from that side where there's the cerebellar lesion. So looking at this, we have a lesion within the cerebellum, so we've lost that inhibitory tone, so now we're going to get increased tone on the side of the lesion because we've lost that inhibitory tone. Additionally, there's going to be decreased tone to the opposite side of the body because there's that inhibitory signal going to the anti-gravity muscles on the other side. So here we have a left-sided cerebellar lesion that's going to cause a head tilt to the right, and a patient that's falling to the right as well. Now, the way that we differentiate paradoxical from central is going to be with our proprioception. So remember those proprioceptive fibers, they start within the limb, travel up the leg through the spinal cord, makes its way to the medulla where its synapses, has input from the cerebellum before making its way to the contralateral side of the brain. So if there's a lesion within the cerebellum and it's affecting proprioception, we'll lose proprioception on that side. So the way that we're differentiating central from peripheral is purely clinical. I can't look at an MRI and say that this animal is going to have paradoxical vestibular disease. It's the head tilt is opposite the proprioceptive deficits. Now, historically, if you read literature, it'll say that a pure cerebellar lesion is not going to cause proprioceptive deficits. And when we have paradoxical vestibular disease, we usually think that there's some brainstem involvement too. Again, with some of the new research on the cerebellum, it kind of disproves this dogma, but there's still some truth to it that it takes a pretty substantial cerebellar lesion to cause at least paw placement deficits. So just to really harp on this, we'll have a patient that has a central vestibular lesion. So it's going to be here within the medulla on the left side. So we're going to lose that vestibular input on the left side of the body. So there's decreased tone on the left. The patient's going to be falling to the left, head tilt to the left. So with a central lesion, that means we should have proprioceptive deficits ipsilateral to the lesion, which in this case we do. So they're falling to the left, the head tilts to the left, the proprioceptive deficits are on the left. So that's how we know it is a central localization versus paradoxical. And this will just be a video that I'll let play and see if you can localize which side the lesion is on. Hopefully you can appreciate the hypermetria on the right side, which should be a clue. So just to go through what we're seeing, the patient is leaning left, has a head tilt to the left, has hypermetria on the right side. So those should all be clues that this is going to be a paradoxical right-sided cerebellar lesion. Paradoxical vestibular with a right-sided cerebellar localization. And now we're looking at the proprioceptive deficits. We'll look at hopping, comparing hopping to the right, which we're saying it's a right-sided deficit or right-sided localization. You see how crisp it is on the left. So always trust your proprioception. That's going to tell you what side the lesion is on if there's any question. And this is just a chart that's kind of going through the central versus paradoxical. Again, the biggest difference is the head tilt is opposite the proprioceptive deficits. And this is just a fun video of a dog with hypermetria. All right, so for those that were just interested in vestibular system, vestibular clinical signs, feel free to stop the video here. Otherwise, there's about 15 minutes left where I'll go through the differentials and potential treatment for cerebellar disease. This is by no means a complete list, but it's a fairly comprehensive list as far as things that can cause cerebellar disease. And in bold, I've put the things that we're going to talk about in more detail. So cerebellar cortical abiotrophy is a genetic condition. Abiotrophy meaning that the patient is born with a normal cerebellum, then over time it starts to become abnormal and atrophy. And on the bottom right, hopefully you can appreciate that there's increased CSF signal around the cerebellum because there's atrophy of the cerebellum. All these are T2-weighted sagittal sequences. And this is just gross anatomical findings in these patients. On the left is going to be a normal cerebellum. On the right is the affected cerebellum. And you can appreciate how much smaller it is. Not only is the vermis smaller, but the hemispheres are as well. And this is just a microscopic view. The left is going to be normal. The right is going to be affected. When we talked about the different cell layers, there was the granular cell layer, which was deeper. That's going to be the most darkly stained area. You can see the white matter that's a little bit deeper to that. And when you compare that to the image on the right, you can see how much less cellularity there is. And then looking even closer in the bottom images, on the left is your normal Purkinje cell layer. Those giant cells are the Purkinje cells. And then on the right is going to be the affected cells, or the affected cerebellum. And you can see that there's only 2 or 3 Purkinje cells that we can make out in that cross-section. So again, abotrophy, degeneration of a normal neural cell population after birth. There's a number of different breeds that have been reported. I have them listed here and the age of onset. But the breed that probably is most well known is going to be the American Staffordshire Terrier, because these patients, it's pretty widespread, unfortunately, this condition. And it's usually late onset. So these patients are a few years old when they start having clinical signs. So 4 to 6 years of age when they start presenting with clinical signs. And it's slowly progressive, which in a sense is good news because the owners have time. But in another sense, it's hard to manage a large breed dog that's having gait issues for years. And although the signs start with cerebellar disease or cerebellar signs, eventually it progresses to where they're so unstable and weak to where they can't walk, and they can have cognitive changes too with this condition. And again, it's somewhat ubiquitous to where 1 in 400 Staffordshire Terriers in the United States are thought to be affected. So not an uncommon condition. And we talked about the findings that you would see previously. Unfortunately, just like with most degenerative diseases, there's no treatment that's available. This condition's a little bit tricky as far as where to put it in a lecture. I'll just mention it here briefly, Chiari-like malformation, because there are cerebellar changes that happen, but these patients usually don't present with cerebellar signs. But it's a common condition, so I'll talk about it right now. So here we have the cerebellum that's normal shaped, and then hopefully you can appreciate that this cerebellum is herniating through the foramen magnum. And Chiari-like malformation is the term that's typically accepted right now, but it's often referred to as caudal occipital malformation syndrome, or COMS as well. And the clinical sign that usually is why these patients present is going to be related to the syringohydromyelia, that increase CSF within the spinal cord. And this is just a CT that's showing some of those malformations that are present. So just to orient you, C2 is the arrow on the right, C1 is the arrow on the left. We're looking caudally, and this is what's called that keyhole malformation that we often see in these patients. As far as why the clinical signs occur, there's a number of different reasons as to why the syrinx is thought to occur, but basically there's a change in the flow of CSF. It's typically thought to be more of a turbulent flow, and for a number of different theorized reasons, that leads to an accumulation of CSF within the spinal cord. The most common breed affected is going to be the Cavalier King Charles Spaniel, but other toy breeds are reported as well. The clinical signs can be variable, so it can be these phantom scratching episodes. Sometimes it's so persistent that the animal can barely walk or function because they're just constantly wanting to scratch. If you've ever had a severe itch, you can understand what these patients to some degree are going through. But it can progress to having episodes of pain, ataxia, and weakness too. As far as the treatment, we usually put them on some sort of neuro pain medication like gabapentin or pregabalin. We might do intermittent treatment with prednisone. Or if they're not responding to the gabapentin, then we might put them on prednisone long term. And then if those medications aren't enough, or if the owners want to be more proactive, we can do foramen magnum decompression. And this is just a recorded surgery of us doing that. We've removed the temporal bone and the cranial portion of C1. And now we're just breaking down some of the adhesions. Hopefully you can appreciate the CSF that's flowing there. But the thought is if we remove this bone that's compressing the cerebellum, that's going to decrease some of that turbulent flow of the CSF. There's actually studies that have shown that the syrinx can actually decrease in size. Maybe not 100% go away, but it can decrease in size after this. And here you can see us breaking down some of those adhesions that can sometimes form with this condition too. This is another condition that you should be familiar with. So this is going to be cerebellar hypoplasia. So cerebellar hypoplasia typically occurs or does occur in cats from infection with the panleukopenia virus. The granular cells are rapidly dividing during the perinatal period. So either right before or after birth, these granular cells are multiplying. That's when they can be infected with the panleukopenia virus. And what this image is depicting on the left, that red is showing that there should be no granular cells there. And on the right, the red is showing that there's granular cells that are present even above the molecular layer, and they migrate down to the normal area. But during this period of migration, replication, this is when they can be infected. So the clinical signs is typically this cerebellar ataxia, the hypermetria, as you saw in that video. It's usually noticed when the animals try to start walking, so after a few weeks of age. The nice part is most of these cats will be able to compensate with time, and the clinical signs can resolve with time. Maybe not 100% go away, maybe they're not the athlete of a normal cat, but typically those tremors, the hypermetria, is barely noticeable when these cats are older. There's no treatment, so bottom line is, with those patients, don't euthanize them. Canine herpes virus is a little bit different. It's also a perinatal infection. It's thought to be for the same reason. Clinical signs usually occur within the first couple weeks of life when the animals start to move. This is a highly fatal infection, and there's usually other signs that are present too, other organs that can be affected with canine herpes virus. Canine distemper virus is another virus that can cause cerebellar signs, but just like with the herpes virus, there's usually other clinical signs that are present. So younger dogs usually have what's called a polioencephalomyelopathy. So it's more of a gray matter disease. Unfortunately, these patients usually have a history of seizures and they rarely survive. If they do survive, they usually have long-term clinical signs. They can be severely paretic or even plegic. So unfortunately, it's not great in these younger dogs. Older dogs, though, can get more of a leukoencephalomyelopathy, so it's more of a white matter disease, to where the virus is within oligodendrocytes, and the oligodendrocytes kind of shut off the mechanisms for myelin repair when the virus is present. So there's not really much inflammation. It's just this demyelination disease that's occurring. And this is just an example of what this can look like if they have cerebellar signs and that demyelination that's present. On the right is going to be a post-contrast T1. I'm sorry, these are both T2 images. On the left is a normal patient, and on the right is showing hyperintensities with that demyelination present. And this was just a dog that had myoclonus from distemper. And this dog would do it even when they would sleep. That myoclonus, that repetitive myoclonus. FIP can also cause cerebellar signs. As you can see on this MRI, it's no surprise as to why. Nice part about FIP is the GS441524 does seem to be fairly effective. It's reported that it can help about 75% of cats that have CNS signs, which is quite remarkable. And that includes cerebellar signs. Again, depending on what part of the cerebellum is affected is going to dictate the clinical signs we see. Is it the cerebrocerebellum? Is it the vestibular cerebellum? Could it be all of the cerebellum? So just something to keep in mind. And then, of course, other infections can cause cerebellar signs. Not a complete list, but just some others to keep in mind. GME is another common cause of cerebellar signs. So non-infectious meningoencephalitis. I put GME instead of MUE because the necrotizing forms of meningoencephalitis are not thought to infect or affect the cerebellum. So that's why I put GME instead. But technically it should be MUE. And this is just an example of a patient that had MUE within the cerebellum. And then that's going to be different than the corticosteroid responsive tremor syndrome. And I'll just briefly show a video that kind of differentiates these two. Other names for this corticosteroid responsive tremor syndromes, the little white shakers, idiopathic cerebellitis. And just like with MUE, this is thought to be an immune-mediated condition, and it affects the entire cerebellum. So here we see contrast enhancement of the meninges of that cerebellum in a dog with corticosteroid responsive tremor syndrome. So looking at these two patients, the patient on the left has the corticosteroid responsive tremor syndrome. So you can see the hypermetria that's present, but more importantly, the tremors that are constantly present, versus the patient on the right was a dog that had MUE. So there were more neurologic signs than just cerebellar signs in the patient on the right. We can see that there's paresis that's present too, and that's because there were other parts of this dog's nervous system. So he had a myelitis, he had regions of the medulla that were affected. So typically the patients, when we're trying to say, is it the steroid responsive tremor syndrome or do we think it's MUE within the cerebellum, the clinical signs are quite different between the two. Then, of course, neoplasia can affect the cerebellum. Again, not a complete list, but some of the more common brain tumors that we'll see within the region of the cerebellum. And just a couple of images. That's a meningioma. On these images, these are T2 weighted sequences, and then a glioma. So intraaxial tumor, again, T2 weighted sequences. And then finally, our last etiology is going to be vascular. So hopefully you can appreciate the sharp demarcations in this T2 weighted sequence compared to the previous two images. So this was an animal that had a stroke. So cerebellar infarctions are actually quite common. Just like with any stroke, it's going to be a peracute onset, so clinical signs occur suddenly. Half the time we can't find an underlying etiology, but just make sure we rule out all causes or as many causes as we can for infarction because we want to treat that. Most of the time it's not recommended to put these patients on an antithrombotic medication. At least that's kind of the old dogma, but it seems to be changing, especially as now we have TAG that's available, so we can get a little bit more objective data. But it's pretty rare that they have a second infarction, at least one that's clinical, even if we don't put them on anything. So I'll leave it at that with the cerebellum and the vestibular system. Again, just let me know if you have questions.